Hey, how are you? No, yeah, you didn't have it on Joker. Now? No? Got it? So do not understand anyway, so that is something. That's don't worry about that. That's camera. I'm there now. That doesn't work. I'm not working now. Right, do you want me to do second screen? No? Done. Paul, I'll restart the computer. Okay? Fuck off now.
Hi there, just letting those who are online know that we're just having some technical difficulties and it'll just be another minute or two. Thank you. Hi everyone. We might get going. Apologies for the delay, but I'd really like to extend a warm welcome to everyone who is joining us, both in person here, online as well. We're delighted to host our second transition year information session, which aims to be a one-stop shop for students to gather an understanding of the therapy professions. My name is Libby Murray. I'm a dietitian working on the National Burns Unit here in James's. I'm one of the clinical nutrition managers, and I'm representing the Scope leadership team here today as well. So Alison Enright is our director. She's the Scope director, and unfortunately, she can't be here today, but she would have loved to have been, and she extends a really warm welcome to you as well. So the Scope team represents the 5 specialities or disciplines, and they are, as you can see on the screen behind me, social work, speech and language therapy, clinical nutrition, occupational therapy, and physiotherapy, and the E stands for excellence. So we're the largest therapy directorate in an acute hospital in Ireland with approximately 270 staff, representing 8% of the clinical workforce in St. James's Hospital. We deliver services across a range of specialities: cancer, neurology, cardiology, and older persons care. Our work focuses on supporting prevention, diagnosis, and to promote self-management, recovery, and well-being. So moving on to the format of this session, there's going to be presentations from all 5 services. So the first 3 will be medical social work, physiotherapy, and speech and language therapy. And then we're going to have a short break where there'll be some tea, coffee, and pastries outside. And then the next 2 sessions will be clinical nutrition and occupational therapy. So after that, we're going to have a very quick survey via a QR code that will take about 1 minute to complete. We'd be really, really grateful if you could complete this, as feedback is really, really important to us, as this is going to be an annual event. And we just would really appreciate any feedback that you can give us just to make it better and better each year. There's also going to be a box, or there is a box at the back of the theatre. So if you have any questions, there's pens and Post-its. If you want to just put them in the box, and at the end there's going to be a session where all of the professions will answer any questions. So there won't be questions after every presentation. All of the questions will be at the end. And then finally, just a couple of housekeeping bits. So the fire exits are to the back of the theatre, where you come in, and when you leave the theatre, there's exits to the right and the left. There's also toilets down to the left as well. And Trinity College have very kindly let us use this room. So if you can just not bring in any tea, coffee, or pastries or anything like that from the break, that would be great. We just really hope that you enjoy this afternoon. So I think we'll get going with the presentations. So I'd like to welcome up Juliet and Ailish from Social Work. Thank you.
Hello everybody, it's lovely to see you all here and very welcome, as Libby said. Myself and Ailish are just going to present for about 10 minutes or so in relation to the role of the social worker in general and specifically in the hospital. So just a little introduction. I'm Juliet Herbst. I'm one of the senior medical social workers here in the hospital. And actually I've been here for over 28 years now. So I started I did a social science degree in UCD. I then went to London and I worked for many years in residential care, social care in the London setting. And then I did a master's in London in social work. And I came back here, a short-term contract, and I've been here ever since. Just working over lots of different areas in the hospital, including at the time when HIV and AIDS was something that had no treatment, which had obviously lots of psychosocial issues presenting with that, sexual health, stroke, cancer care, and medicine for the elderly. And I'm back in cancer care now. And Ailish?
Yeah, so my name is Ailish Walsh. I'm a main grade social worker here at the hospital, so would be a newer staff member in comparison to Juliet. But yeah, I've worked here for about 2 years, and before this I was working in the community. I was working for TUSLA, so working with children and families. So we're just going to talk you through kind of the role we do here and social work in general.
Great. Good. So I'll just put this up really. Sometimes when we introduce ourselves and we say we're social workers, sometimes there's a connotation of somebody with a lot of power who maybe is going to come along and take children away and cause havoc, or somebody who has a magic wand and has all the solutions to all the problems and can get people houses and solve all the other problems and issues. So we'll tell you really a little bit more about specifically what we do. So we work as part of a multidisciplinary team here in the hospital. So alongside our other allied health colleagues, doctors, nurses, and our role is specifically to assist patients and their families resolving any practical or emotional difficulties that they experience due to their illness. So breaking that down a little bit, we may get a referral for somebody perhaps who has come in for some elective surgery. They have had perhaps they've had a fall and their leg is broken and they can't work anymore, and they have lots of personal responsibilities at home and concerned about bills and how to manage things with childcare, how to manage all the new information they've been given medically about what's happening. Perhaps they might need some advice around how they're going to adapt things at home. So as a multidisciplinary team, we help to advise people or direct people to what they can do in relation to this. Sometimes the impact of a medical diagnosis, say for example a cancer diagnosis, can throw up loads of things emotionally for somebody. How am I going to cope with this? How am I going to talk with my children? What about the life changes that are all going to be happening now when I embark on a long road of treatment? And social workers are there to work along with our colleagues to offer somebody that little bit of extra support, whether it's on a one-to-one basis or whether it is a crisis sort of brief intervention, or whether it is supporting the carers and the families of the individual involved. We're also involved in a lot of kind of teamwork stuff in relation to discharge planning. So we work again with our allied health colleagues in relation to that. So it might be about making referrals to community resources for funding for home supports or linking in with other community-based services. And Eilish will tell you a little bit more about that. So we would coordinate family meetings and ensure that we advocate for the services that people need. Sometimes there's a little bit of balancing sort of risk maybe attached in our role. So perhaps somebody is coming in and there's actually a safeguarding concern. Perhaps there's vulnerable there's children at home and there's concerns about who might be looking after them, or there may be a concern for an older person who's cognitively not very well at the moment, and there's a worry that actually somebody is taking advantage of them financially. So social workers can come in. Sometimes we would need to make a comprehensive assessment about the situation, investigate what's going on, and sometimes refer out, whether it's to TUSA services or to the safeguarding teams in the community too. All that kind of stuff can sometimes involve a lot of paperwork and detective work in terms of finding out what exactly is going on. But it's to help ease the burden and to work with our colleagues so that a holistic care is offered to patients when they come and attend the hospital. And sometimes it can be quite juggling and quite busy. So in terms of who benefits, we work with people of all different ages and all different backgrounds who end up coming into the hospital. And we also work with their families, we work with their carers. And, you know, for example, I'm involved in the cancer area, and we do group work with children, supporting them therapeutically over a 6-week program. It's called a CLIMB program, where we give young people the language in terms of expressing how they feel and give them some information about cancer and that kind of thing through art and play. So it's a diverse range of people that we work for. And I'll hand you over to Eilish.
Thanks, Juliet. So as Juliet said, we are medical social workers, so we're based here in the hospital, but I suppose social work is a career that's not just based in hospitals, and it's a career that's really broad. So there's lots of different places that social workers can work in the community as well. So social workers work in homeless services, in probation services, addiction services, schools, intellectual disability services. So that's the good thing, I think, about social work, is that if you start in an area and you find not really my thing, you can kind of move, and there's lots of different roles in it. I suppose in medical social work, we often have to liaise with different social workers in the community and different community agencies and organisations, to kind of make sure that when a patient would leave the hospital, or if they're an outpatient, that they have enough support and help at home, so that there's kind of follow-on care. So I suppose things to think about, and if you're looking to maybe go into social work in terms of skills and interests, social workers are usually people, good with people. They're good with communicating. A lot of our job is talking to patients, to families, talking on the phone. We're always talking, so communication is a really important skill. We're usually good at planning and organising. As Juliet said, one of our jobs here in the hospital is organising meetings with families to kind of ensure safe discharge plans for people. We work closely with our multidisciplinary team, so teamwork is really, really important. For example, if the occupational therapist did their assessment and said, this patient is not going to be able to kind of get dressed on their own in the morning, they're going to need a little bit of help, that's where we kind of come in and we organise that help. So it's all about teamwork and time management as well. We can be really busy on a day-to-day basis, so it's important to kind of learn how to prioritise and get the things done that you need every day. Overall, I suppose social workers are usually caring people, and they kind of want to make a difference in people's lives, and they have an interest in social justice as well. One thing that does come up a bit is what's, I suppose, the difference between social care work and social work. So while they're related, they are two different professions, so there's a different pay scale and different qualifications for the two jobs. Social care work would be more hands-on practical support, whereas social workers would be, I suppose, involved in more the management of the organising of care. Lots of people start out in social care work, and then they might go back to college and decide that they want to, I suppose, pursue a career in social work. And social work would often have other responsibilities and duties, such as going to court and different things like that. So while they are very similar, they are actually two different professions. So I think that's important to know. So things to consider when thinking about a career in social work. I'm a main grade, so that's where you'd start off when you would leave college, but you can progress further to being a senior practitioner, a senior social worker, a team leader, or a clinical specialist. The starting salary would be around 42,000, and if you were looking to go up to being a principal social worker, I suppose you could go up to the top of the scale there to the 97,000. In terms of annual leave days, it's around 29 days a year, so it's very good in that respect. And just to say, there's lots of different pathways to getting into social work. So sometimes people, I know, can be really upset if they don't get their first course, that things don't go their way in terms of the leaving cert. But there's lots of different avenues to get into social work. You can do a PLC and then go on maybe to do the undergraduate degree. I did the 4-year undergraduate degree in Trinity, and I would really recommend that if anyone is interested in social work. You could do a master's degree. There's lots of different places around the country that do them. If, say, you started off in a particular, doing a particular degree and then changed your mind. And there's also a new social work apprentice programme that started out. So there's lots of different backdoors into professions. So I think that's something just to be mindful of. So we've just some photos here from our department. As you can see, there's a big group of us, and it's, I suppose, the importance of teamwork is really promoted in our department. In terms of my job, I suppose there's lots of things that I like about my job, but the main thing is getting to help people every day. I work on the trauma team, so all of the patients that I see here in the hospital every day are in the hospital because of some traumatic event that's happened to them. So they might have had a really bad accident, they might have lost their house, they might have, I suppose they might be homeless. I also work on the burns unit, so sometimes people can come in and they've had a fire in their house and they've nowhere to go when they leave the hospital. So while they're navigating the medical situation, there's also the social side of things. So I think you're just that support person for people, and people really appreciate it as well. So I suppose that's the main thing that I like about my job.
Yeah, and I think I was just going to add what I like, obviously, because I've been here that long, there's a lot that I really love about being a social worker. I think there's lots of diversity working within a hospital, depending on whatever area of medicine that you work in. And what I love is actually working as part of a multidisciplinary team, working and adding my bit, adding the bit where you can offer and address people's social and emotional care needs. And make that little bit of a difference in somebody's life. So that's it.
And that's everything from social work, and we'll have some questions then at the end. Thank you.
So, hello, my name's Alex. I'm one of the physiotherapists here working in St James's. I also work with Trinity Rugby as well, and with some of the scholarship athletes across all sports in Trinity. So I want to start by talking a little bit about myself, what's brought me here, and then I'll talk more about what physio is like as a job and how you get through college. As I said, I'm working here in James's. I have been here for 3 years now across a number of different services. I am currently doing an extended rotation, which means I'm specialising in the outpatient area. I have been through rotations in stroke, care of the elderly outpatients, care of the elderly inpatients, and ICU are the main ones that I have done. So I suppose the main thing about physio is that it's incredibly varied. I know when I was in school and started looking into doing physiotherapy, I didn't really understand that physiotherapy has a massive role in the hospital. I think when most people think of physiotherapy, they think if they get an injury playing sport and they go see kind of somebody in private practice. And that was definitely my experience with physio. Played a lot of sports, got injured a lot, spent a lot more time with physios than I would have liked. But I realized very quickly as I was doing my kind of research into the course that most of what we do in college and most physios working are working in hospital, so it's a massive role. But you can also be working across loads of different areas, whether it's sports, whether it's private practice. Most people here have probably seen a physio in private practice at some stage. Could be in the community, they could be supporting people in the community with needs, whether that might be strengthening at home, making sure people are staying out of hospital. There's a big role in paediatrics, across disability, inclusion health, working with homelessness, refugees. So it's a really wide and varied profession with, I suppose, avenues into all areas for people of all interests, which is kind of an important thing for any person going into kind of a possible career. I have a few photos up here. The first two are in Trinity College, where I do a lot of my ed hours work, let's say, and that's College Park. The one in the middle is as we won a cup semi-final there. I was then away for the final, which we lost, but we won the semi, and there was the photo to prove it. So I suppose that's very different to what I'll be talking about mostly, which is hospital based today. But I wanted to give you a little bit of an insight into what I do working with a sports team as well. I do 2 clinic evenings a week there, so I finish up here at 4 o'clock and then pack up my stuff and go over to Trinity. And I see any of the athletes coming in that have been injured on the weekend from matches, training, maintenance programs, ongoing strengthening. And then most weekends we have a match. That could be anywhere. Home games are always easier, like any sports. But then we have down at the end, I have a photo of one of the guys that broke his hand playing in a match. I think that was last year that he did it. I don't get when we have an injury, we send most people to hospital with a significant injury, a hand fracture like that. You can see, I don't know, is there a marker on the screen? These are two spiral fractures in his hand. So I don't get to see most of the injuries, but every now and then one of the guys will send me a photo, and that's one of them from last year. But we get lots of training into managing an injury like that and what to do. Talking a little bit more about what a physio is like in a hospital, there are three main areas. The first is musculoskeletal. So what that means is that's the thing that you probably think of when you think of physios. So muscles, bones. So that might be after somebody has a fracture or a break or a dislocation, maybe a muscle tear, something like that. There is respiratory care. I know I definitely, when I was in school, I didn't know anything about this. And physiotherapists have a large role in the ICU and also in respiratory wards. So that's breathing is the main key. And people, when they get sick, you might have heard, you have a cough, lots of phlegm. And a large part of our job is helping people who can't get rid of that phlegm off of their chest. Seems kind of gross, but you really get used to it. So it could be lots of people, they might be ventilated, could be sedated, in an induced coma, something like that. And it's our role to help with that. We get lots of additional training for that. That's called, when we go through that training, we become what's called on-call competent, which means that here in James's, probably once a month, we're on call overnight. So that means that if somebody gets sick out of the standard hours of kind of your 8 to 4, someone will give us a call, and there you are on your way back into work to see somebody. Like, it might be in the middle of the night. I was on call last night, I didn't get called. I was on call last month, I got called in 2:30 in the morning. So it varies, and we do about 3 weekends a year as well. So that's the kind of a big area. And also neurology is the big area. So that might be things such as a stroke, might be something like Parkinson's. So there's two very, very different types of neurological injuries. One is, which is Parkinson's, slow and over time, and then a stroke might be overnight. So while it's still a nerve injury or a brain injury, they present very differently, and we need to do lots of different things despite it being a nerve injury. A physiotherapist can work in inpatients, so that what that means is with people in the hospital. They can work with outpatients, which is when people come in to see us. That's the area that I am in at the moment. So people who have been in hospital, or maybe haven't been to hospital but have gone to see an orthopedic consultant outside who have sent them to physio, maybe with a rotator cuff injury, or they might have had something like an ACL repair or a knee replacement, and they come and see us in the hospital from home, and then we run lots of exercise classes as well. Some of them in the community, some of them in the hospital, and some of them for inpatients as well. We work very closely with all the other members of the we call them scope team here, the allied health, as you might have heard them called. We very often do joint sessions. So myself and Jack, for example, will be speaking later, have seen lots of patients together. So a physiotherapist and an occupational therapist might go see people together, because lots of people who we see in hospital will have physiotherapy needs, but also occupational therapy needs, and we can help with that. I love my job because it's varied. I think I've spoken a lot about how varied it is already, even across in my 3 years in James's, how many different things I've done. But also when I go to work in Trinity, it's a totally different job. Like they seem polar opposites at times. In the hospital, most of the time it's very controlled. I know what's going on. But in Trinity, the side of a pitch, someone goes down, often it's firefighting, and you're trying to keep somebody, I suppose, managed until an ambulance arrives, or there could be blood pumping everywhere, and you've got to get that sorted. So sometimes it's a bit chaotic compared to the hospital, but I love that. It's definitely busy. I think most physios you meet will all say that they like that about their job, that it's busy. I definitely hate kind of having free time. I'm always doing something, and I think that suits me for work. It fits in. I like my sports, so I'm working closely with sports and with athletes, and also encouraging that in the general community of getting people to be as active as they can, which is a nice part about that. It is a professional degree, which is kind of something that we kind of look for, and you'll see that if you're applying for jobs later on. It's one of the kind of the key highlights is that you're looking for that professional degree. The work-life balance is really good, if you want it to be, is what I'll say. The standard hospital job is probably 8 to 4, so that's what I am here in James's. I choose to do additional work to stay involved with sports, but if I didn't want to do that, I could do my 8 to 4 and then have all of my evenings free. So it's and once you leave work, the work stays there. It's not like you can take home. You're not doing emails at home, which I think is a big thing for lots of people. Like the work stays in work, which is nice. There's also lots of exciting opportunities. Like, for example, this weekend I was working with the Irish University's rugby team as we played the Irish under-20s as a World Cup warm-up game. So we were in the Radisson Blue for the weekend in Still, Oregon. We did all our pre-match there, fed lots, and getting to work with like international athletes, which is really, really exciting. There's a photo of me there as well with Anya, one of my really good friends. Came through college with her, and we went over to Bordeaux with the Irish under-18s Swiss rugby team. So that's a photo of us with the jersey. That was I didn't get an Irish jersey as a player, but got it as a physio. So that's lots of exciting things to do. In regards to career progression, there's 4 main kind of types of physiotherapists in the hospital. There's a staff grade, which is what I am. You are the staff grade for at least 3 years of working, and then there's a senior, which is one band above. A clinical specialist is one band above again, and there's a new grade coming in called an advanced practice practitioner. There are very few in the country. We're very lucky that we have one here in St. James's working in the emergency department. One of the big things they're looking at is injection, which physios can't do at the moment. And probably in the next month, we'll be able to order x-rays, able to order MRIs, which will make a massive difference for our job. We lose a lot of time having to send people back to GPs or send people back to consultants when people are in a lot of pain, and we are pretty confident they have an injury, but nothing can be done until it's confirmed on imaging, and we can remove that step if we get imaging. So that's exciting for the role and for the profession. In regards to non-clinical, there's lots of options as well. It's college tutors, lecturers, research. There's a good few of the people from my course who never went into any clinical practice. They went straight into research. And it's a big role in corporate as well, and that's definitely evolving. Lots of the big corporate multinational companies are hiring physiotherapists, encouraging activity levels, working in managing kind of a lot of desk-related pain, desk setup, that kind of thing. So that's an emerging role for the profession as well. In regards to what's helpful in school, the 2 main sciences are a requirement for, I think, all but UCD, I think, off the top of my head. I did chemistry and biology, but what I would say is that the advice from my guidance counsellor was definitely have 2 sciences, and they're the ones. I know PE has come in since I started, and that has been highly recommended as well. In regards to where you can do the course, I did it in Trinity as an undergraduate, so I came straight out of school. The points for Trinity last year were 577, a little bit higher in UCD and UL, which are 588 and 590. UL is normally a little bit higher because it's the only one in Munster, and the rest are kind of quite close. As of last year, the undergraduates started in DCU, and then there's a couple of master's degrees. UCD, RCSI, UL, UCC, and Trinity are starting one this year, starting 2025. And then there's a new one as well in the Portobello Institute. that is not, you would need to do additional time and placement work outside of that. You can work out of all of the other courses on this list, you can work immediately as a physio once you have your registration. There is additional things to do for the Portobello one, so I would just keep that in mind if you're picking. But there are lots of options if you don't get it through college. The points are really high. They've only gone up since COVID, but there are lots of options. So any of the science degrees, you can then do it postgrad, do the masters, or go back to do it as an undergraduate as well. I have lots of friends who've gone back and done it, and loved it, even though they're not coming straight out of school. So what's it like in college? So it's a 4-year degree. The first year is normally background learning, so that's all of our anatomy, our physiology. Anatomy was probably my favourite thing in college. So what that is when people pass away and they donate their body to science, we get to learn all about the muscles and the body and the bone, the organs, using real life cadavers, which was a shock to the system initially, but very quickly you get very used to it. And it was my favourite thing in college. It was incredibly interesting, and yeah, something that I kind of wish we'd had more of as we went on. Second year is mostly practical, so that's the hands-on work, our assessment skills, our treatment skills, things to get ready for us to go on placement. And then in third and fourth year, we go on placement. About half of the time, maybe a little bit more, is spent in the hospitals or in clinics, learning to be the physio that you will be. I think most people would agree with me that I did most of my learning as a physio on site, like putting in that work. It's so different being in a classroom compared to being out there in the hospital. And then in fourth year as well, you have a thesis in Trinity. That was an experience, lots of library errors, but good to have done. There's a photo of my graduating class there in the middle, and then a photo of me looking nice and smiley on my graduation day. So thank you very much, and best of luck. And if you have any questions, there'll be a panel at the end. I'll have to answer questions.
Okay, hello guys, my name is Sinead and this is Sage, my colleague, and we are speech and language therapists who work here in James's.
So just a bit of background, I'm currently covering the general medicine caseload at James's, and I've been here since January.
And then I am currently covering the acute medical assessment unit, which is our short stay unit, and then also training up in ICU at the moment.
So broadly, what is a speech and language therapist? So a speech and language therapist is responsible for the assessment, diagnosis and management of communication and swallowing disorders. And we work across the lifespan, so with children and adults in a variety of settings. We're health and social care professionals, and we work as part of a team, as that's been discussed a lot today. So with doctors, nurses, teachers, and our lovely HSCP colleagues. So if you enjoy working with people across the lifespan, being a team player, possess good communication and leadership qualities, then I think you'd be really interested in a career as a speech and language therapist.
And so who we work with, so we work with people, just like Sage was saying, across the lifespan from birth to elderlies, or elderly people. So a speech language therapist is mainly concerned with the following medical areas. So acquired difficulties around understanding language, speaking and writing and reading. So this is called aphasia. Then problems with muscle control for when you're speaking, which is dysarthria. Difficulty planning the movement for speech, which is called apraxia of speech. And then problems with social interaction due to cognitive difficulties, which is cognitive communication difficulties, and then problems with the voice, which is called dysphonia, as well as problems with swallowing, which is called dysphagia. So lots of different areas that we're working with.
Okay, so a bit of an overview of what a typical day might look like as a speech and language therapist. So each morning we meet as a team and we kind of discuss new referrals that have come in, as well as the caseload that we're currently covering. And then we might go out onto the wards and attend our meeting with the rest of the multidisciplinary team. So that's doctors, nurses, etc. Then it's hitting the wards, seeing patients, and we might have various other admin responsibilities that we need to attend to. So participating in research projects, or making sure that we're thinking about how we can improve our service, so spending time towards that kind of project. We then might have a joint session with a physio or an OT, another member of the team doing rehab, and that's something we tend to prioritise in our day to ensure they're getting enough intensity in their treatment. We want to be attending training regularly, so improving our skills, so we'll make time for that in the day. Something unique to speech and language therapy is that we also have the opportunity to go to radiology and complete what we call a video fluoroscopy, which is an X-ray of your swallowing. So that's a really cool part of the job. Then we need to set aside time for admin, so writing notes, therapy planning, and wrapping things up for the day.
So this is an example of a rehab session with a gentleman who has apraxia of speech. So what this means, I suppose, is that what he is wanting to say in his brain isn't coming, I suppose, to the muscles of the mouth for him to exactly say it. So it was a joint session with a music therapist, which we have in the hospital. So let's see if this plays.
And Tom, remember, music and Marina, our lips are touching. Well done. So our tune was music with Marina. And as slow as you like. So don't forget to breathe in
Breathe
first
in
through your
first,
nose.
Tom.
Breathe in. Music. Breathe in. Platinum, breathe in.
Sorry. So for this gentleman, he found it very difficult to speak after a stroke, so he was up in our stroke rehab unit. So this was huge, I suppose, making gains for him, even speaking at that short kind of phrase level, which was a huge achievement for him.
And Tom,
Very expensive. And then this is our IC unit has recently gotten an eye gaze technology machine, and a gentleman came in who was actually a very suitable candidate for this technology. So this, I suppose, is him first getting used to the machine, and then afterwards I'll show you a video of how he, over time and practice with speech language therapist, was able to use it really effectively.
Dad, I want mum baby, Dad.
Great. So will you rest for a second? Brilliant. So I've met your mom a good few times. I haven't met your dad yet, but I know he's been in. And then, is there a baby in the family that... Your babies, as in your children. Yeah.
And then this, not that one. This is after, I suppose, a few weeks of practicing with the eye gaze technology and with support of Kira, our speech language therapist.
Stroke. With I. Dog. 2. Park. I would like a stroll with my dog to the park.
So this gentleman, he's using his eye gaze to track, as you can see along the screen, and to choose which letter or which words he wants to pick. And you can see there he went from quite basic phrases up to a really good sentence there. So over time in practice, he was able to use it really effectively.
Stroll.
So now we'll go back a few steps to talk about what is communication. So if you think about any conversation, it's a two-way collaborative process where you have someone who is receiving a message, the message is going in, that's understanding, and we can think about the message going out as well and expressing. So communication is a vital process and a basic human right, and it's something we use to exchange information, to develop our self-identity, fulfill emotional needs, making connections with other people and promoting our membership in groups, and it allows us to reveal our competence. So down the bottom there were pictures of different communication aids that we might use in our job for people who might have difficulties with their communication. So like using simple yes and no boards if someone's having trouble with being able to express their needs and wants. So they're very basic, but just a little snapshot there.
I suppose it goes from quite basic yes, no, up to that eye gaze technology, which would be very advanced technology then. So this is, I suppose, like Sage was saying earlier, the X-ray of the swallow that we do in the hospital, and then on the other side, we're going to show you a FEES exam, which mightn't be the nicest, I suppose, to look at, but it's what we do every day, looking at the swallow. So this is the first one. So it's an X-ray of the swallow. You can see there, we're kind of looking side on, and we're looking at the throat. The dark material there that you can see is what we put contrast in food and drinks, so that people drink it and eat food under X-ray, and we can see exactly where the food and drink is going, whether it's going down where we want it, down to the esophagus, to the stomach, or if it's going into the airway, going down to the chest, which we don't want. So this gentleman, as far as I can remember, is what we call grossly silently aspirating. So a lot of the material you'll see is coming into his airway, going down, and he has no response to this, whereas you or I would cough immediately to this. So popping right down there into the airway and going down towards the chest, which is not ideal. Do you want to explain?
Yeah, sure. And this other lovely image that we have here on the right is what we call a FEES, or a fibre endoscopic evaluation of swallowing. So this here, where my mouse is hovering, that is meant to come over our airway when we swallow to protect the airway and to stop food and other materials entering. So a camera is passed up through the nose, and then we can visualize those structures and see what happens when someone swallows. So try and...
First teaspoon of water.
This was in ICU. So you can see the vocal cords there.
Yeah. So that your first, do one of them?
Yeah. Second teaspoon of zero.
Oh yeah, that's not too bad there. I just got a little bit more.
So those are just two video examples of different assessments we might use in speech and language therapy to assess someone's swallow. So yeah, definitely showing you the full array. We don't just work with, I guess, speech and language, despite the name. There's a lot more to our profession, I suppose. And I think these instrumental assessments are a really different part of our role that is quite unique and interesting. Yeah.
First teaspoon. There we go. So areas that a speech language therapist might work in apart from, I suppose, the hospital. So myself and Sage, we obviously work in St. James's Hospital. We've worked in here for a while. Then there's also rehabilitation units that people can work on. So this might be with people with TBIs or strokes. Then schools, so there'll be speech language therapists coming into schools and working with children. Community settings for both children and for adults, mental health settings, private companies, so nursing homes might organise for a private speech language therapist to come in and assess nursing home residents. And then prison services, as well as the legal system court, and legal system and court, and then also charities.
So I think there's a lot that I enjoy about my job as a speech and language therapist, but one thing would definitely be how much learning we have access to. And I think, like a lot of the other presenters have mentioned, each day is different. You learn something new. There are so many opportunities, particularly in the hospital setting, lots of professional development courses or that you might be able to access. And working as part of a team is really rewarding. You feel like you can contribute, but also learn lots from your team members. And I think communication and swallowing, eating and drinking are we take them for granted day to day, but they are so integral to everything we do and such an important part of being human. So I think it's really valuable being able to work as a speech and language therapist and make a difference in that part of someone's life.
I suppose, like I was saying, there's loads of things that I do love about my job. One in particular is that every day is different working in the hospital. No 2 days really are the same. And that's whether it's different caseload with patients, different patients coming in, or it's new learning opportunities. There's just a wide variety every day. Improving people's ability to eat and drink, just like Sage was saying. I suppose like chatting and eating are kind of two of the best things in life, really. We do them every day, so it's really important, I suppose, and really rewarding, helping people get back to chatting and eating just as they were before their acute stay in hospital. And then, like we were saying, continuously learning, so every day we're kind of learning something new, or else going out to CPD events to learn more, to come back and bring that knowledge back to our colleagues and share it with them.
So career progression opportunities. Myself and Sinead are both staff grades. So from there, you can develop up to being a senior speech and language therapist, and then a clinical specialist speech and language therapist. There's also the opportunity to work with students and be a practice tutor. We have some students with us on the general medicine caseload at the moment, so that's really exciting to be working alongside them and helping them to develop their skills. And then you can work up to being a speech and language therapy manager as well.
So kind of similar to the other HSCP colleagues there, but our starting salary is 44,000, and this can grow up to 97,000 with career progression. I think that's a manager's pay. And then we get 30 days annual leave, or I think it's 29 or 30, which is really nice. And then we all get our 10 days public holidays. I'm probably tired to say this. So I suppose just if you're looking to go into speech language therapy and like course wise, I've taken this just from the Trinity College, but there is obviously different colleges which we will touch on. But you need 6 subjects, a minimum of H4 in 2 subjects, and a minimum of a H7 or O6 in 4 other subjects. English and Irish are requirements specifically for Trinity, I think, unless you're exempt from Irish. And then you require a H4 in a lab subject such as biology, chemistry, physics with chemistry, or ag science. And then where you can study speech language therapy. So I did my undergrad in Trinity College. Sage did it in Australia. You can also go to Cork University, NUI Galway, so they both do the undergrads. Then for masters, they have it in Limerick, which is really good. And then also other routes, I suppose, if you don't get either the points or if you don't get a first time round for the undergrad, you can go through the Northern Ireland system, which is the UCAS. I think that's something different. The UK system is the UCAS, which will obviously include Northern Ireland there. And then there's also speech language therapy assistant courses. So for some examples of where they are, so Dundrum College, Pearce College, Cavan Institute, and Waterford College. So they train you up to be a speech language therapy assistant. I think, as far as I know, it's 1 or 2 year program. And then from there, if you are really interested and passionate about it, you can go on to do the undergrad.
Something I thought I'd mention, just ad lib. Obviously, I studied in Australia, but something that you can do with a lot of HSCP roles is kind of develop your skills, study here, and then there are opportunities to work abroad, but you do have to go through a registration process, but that's just something to note. Thank you for your time,
Thank you so
everyone.
much, and we can answer any questions afterwards.
Great, so lots of useful information there. So we are going to break for 15 minutes. So if we say to come back around 2:20, so there's tea, coffee, pastries outside. And yeah, we'll see you back here in about 15 minutes. Thank you.
it wasn't like I had to warm up. No, exactly. It was quite nice that it wasn't people's voices. We went around yeah. No, can't leave it. Yeah.
So welcome back, everyone, and we might make a start on the second part. So the next part after the break is going to be clinical nutrition, and we're going to be hearing from Magella. And then after that, it'll be occupational therapy. And then we might get you to do the survey really quickly, and then we'll have the panel discussion where we'll answer any questions that anyone has. Thank you.
So, hi everyone, my name's Magella and I'm one of the dietitians here. I studied in Trinity College, Dublin, and formerly DIT, so it's TU Dublin now. And I worked a year in industry before I started working here then in 2018. So I'm a senior dietitian and I work both in critical care, so that's in like our ICU department where people are like in a coma and they can't eat and drink, so we have to feed them through like feeding tubes. And I also work in outpatients, so in the clinic environment for narcolepsy, which is a sleep disorder. So they're the two areas that I'm working here in the hospital. So what exactly is a dietitian? So we're a healthcare professional, like all of my colleagues here today, and we have a university degree specialising in nutrition and dietetics, so that's very important. And we've completed a period of training in a hospital and community setting, so that's 100 hours, and that's incorporated as part of your degree that you're doing. And that placement is not paid as well. So what we do is we're an expert and we apply the science of nutrition to promote health, treat and prevent malnutrition and other diseases, and provide dietary guidance and advice in terms of health and illness. So what does a hospital dietitian do? So we help diagnose and treat malnutrition. So often when people hear you're a dietitian and working in a hospital, they're like, oh, I'd love you to put me on a diet or tell me how to lose weight. But actually 1 in 3 patients that come into hospital here are malnourished. So that means they've lost weight, they haven't been eating well, and their weight is quite low for their height. So we're the experts that come in then and we can diagnose malnutrition and help treat it as well. And part of that diagnosis is we can do a physical assessment, so we can check someone's calf circumference, and by doing that, that can tell us what their muscle quality is like or how much muscle they have. And we can do a hand grip strength, so that tells us how strong they are, and that can help us devise what energy they might need and what protein they might require as well. With that, we can then prescribe oral nutritional supplements, and these are special nutritional drinks that are high in energy, they can be high in protein and have different vitamins and minerals. And there's often ones that are disease specific. So if you come in and you have a wound, you might need one that has extra vitamins and minerals to help with that wound to heal. We always go food first to begin with, so it's always we try food and then we go to oral nutritional supplements. And one diet could be like a high energy, high protein diet. So we would advise people on how to eat little and often and get the most nutrition out of their meals, having 3 meals, having 3 snacks a day, and how to optimize this. And with our speech and language therapist, you saw earlier that they are able to assess an individual's swallow, and they guide us on what swallow someone has and what their recommendation is, and then we educate them on the kind of diet that is with the modified consistency, and we then advise the patient on how they can meet their energy, their protein, and all their vitamin and mineral needs being on a modified diet. So that could be liquidized, smooth pureed, minced and miced, it could be soft and bite-sized. So there's a variety of diets there that we then educate patients on. If people can't eat and drink, we can then feed people through tubes that either go through the nose, the stomach, or their bowel. through their intestines. And we're the experts that calculate up and use like maths and requirements to determine how much energy, again, so when I talk about energy, I mean calories in the feed that they need, how much protein, how much fluid, and we also look at like their bloods and we work out what minerals that they need. So minerals like potassium and phosphate, and we ensure that we're meeting the requirements that they need on both a daily basis and long-term basis. And then if someone's gut isn't working, so their stomach isn't working, then we have to feed through the veins and we can give them parenteral nutrition. So this bypasses your stomach, it doesn't go into your intestines at all, and it goes through your blood, and it's like a liquid form of nutrition that's given through a drip. And again, this is very specialised, and we're the people that are calculating out and working what needs to be given. And then people might require a variety of special diets. So you may have heard of like a gluten-free diet for celiac disease. People may have diabetes. Again, they may need to restrict or calculate how many carbohydrates, like your bread, pasta, rice that they're having. So again, we educate people, and people will work dietitians in different areas and in different specialities. So meaning they might work in diabetes, or they might work in gastroenterology, so that's like celiac disease or irritable bowel syndrome, or like myself working in critical care, so in the ICU unit. So where do dietitians work? Like that's been said here today, there's a variety of areas, and that's really good about the career, it's so diverse. So I work in the hospital setting, currently in St. James's. You can work in a nursing home as well. Again, this is for maybe people who are older and you're trying to work out how you can help with their eating and drinking, or they might have feeding tubes as well. In private practice, so you might have your own clinic and have people coming into you to see you for a variety of different reasons. You could work again on sports teams, so sports nutrition. Work in the media, you could be on podcasts, on TV, writing articles. You may decide that you like research and academia, so stay in the university setting, maybe do a master's, a PhD, so advanced education, and maybe lecture in the area that you're interested in. And you could also work for the food industry as well. And like I said, I worked for a year in Abbott Nutrition before I started in St. James's. So that's like a healthcare company. So there's a variety of areas that you can work in, and it's very diverse. So just to give you an idea of a day in the life of a hospital dietitian and what I do and what some of my colleagues would do on a daily basis. So first of all, we're really lucky here. We actually have an electronic system at St. James's. So in other hospitals, or before this, we use paper charts, but everything's online now. And I work on two systems, the ICU system and this system as well for electronic patient records. So come in, check my emails. And the most important thing is, like I said earlier, is being planning, organising and working out who we need to see for the day. So who's the highest priority? And then when you work that out, it's going to see the patients. So that can be seeing the patients on the ward. So this is one of my colleagues here at Niamh. So she's actually looking at a feeding tube that's in someone's stomach. And Niamh is trained up and is a clinical specialist in that area, so she can change the feeding tube within the stomach that the patient has. And then another colleague, Kieran, he's showing how to use a hand grip strength. So as I said earlier, we can test how people are responding to the protein and the energy that we're giving them. Because often it can be very hard to interpret weights. So we check people's weights when they're in hospital, but they might have a lot of fluid on their legs or fluid in their stomach due to different diseases. So this is another really good way that we can check and see how they're responding to the nutrition that we're providing. We'll attend meetings. Again, a key skill is being really good at communication, talking at MDTs. So when we say multidisciplinary meetings, so this is like all the allied healthcare professionals here today, doctors, nurses, and anyone else that's involved in the patient's care. We also talk a lot with our catering assistant colleagues on the ward. They're giving the food to patients. Our healthcare assistants, they're key to guiding us on how someone's been eating on the ward. So we really talk to everyone that's on the ward, because we can give us really insightful information to how our patients are progressing during their time here. We'll also provide educational sessions. So if you work in a specific area, you can give update sessions to your colleagues, so other dietitians, or maybe we'll give education sessions to each other in different disciplines like speech and language, OT, physio, social work, doctors, nurses, so we all learn from each other. Because at the end of the day, we want to make sure that we're doing the best for the patients here. And if we're learning, it's going to give good outcomes for everyone that we're seeing. And then research is also important. Part of our job, we need to make sure that what we're doing is the right thing that we're doing. There'll be a lot of guidance on how we should do things, and we will then check if we're doing them the way we should be doing them, or how we can improve the care that we're providing. What else can we do, and what research is coming out of like universities and different hospitals, and could we put that into our practice, into what we're doing here? And then throughout the day, we're typing up our patient notes so everyone can see them on the system, and the doctors, the nurses, anyone else can see what our plan is for the patient and what we've advised. So the career progression of a hospital dietitian, very similar to other professionals here, staff grade, generally working for 3 years. And then after 3 years, you can apply for senior positions, but you could work as a staff grade for longer. And then if you apply for a senior position, that's more so in a speciality. So as a staff grade, you rotate around and get great experience in a variety of different areas. And being in such a large department like St. James's, our clinical nutrition department has a lot of national services. Like Libby said, the National Burns Unit, we've the National Narcolepsy Unit. So we've a lot of national centres. So you get great experience and great exposure. Then you'll work as like a senior dietitian, so you're working in a specific area. So like I said, I'm working in ICU critical care, so you're working in that area speciality. Then after working 4 years, you can then apply to become a clinical specialist. Again, if the job opportunity arises, then you're a real expert in that area that you're working in. And you could go to management from like a senior clinical specialist level, again with the necessary skills, and you might need to do additional training and degrees at university. Again, pay ranges from about 44,000 starting off, and again the 97,000 here is at the very top end of the scale at management. And these HSE pay scales are all available online, and you can see that we go up in increments yearly until a certain point. And again, annual leave is 29 to 30 days. So how to become a dietitian? So I did the undergraduate route here in Ireland, in Dublin. So that's in Trinity and TU Dublin. 4 years full-time. CEO points range for 2024 was, it ranged 545 to 625. So that's the points that the people got entering into the course. And important to note that you need a H4 in chemistry. So that's important to note there. And then there's also the University of Ulster, again, undergraduate degree. It's 4 years full time, and you need 5 grades at H3 to include at least 2 subjects from math, chemistry, biology, physics, and home economics. And then, like, if you don't go through the undergraduate route, there is a variety of other options, including the masters in different universities. So you have UCD, you have the University of Limerick, you have Cork, so UCC, and you have again the University of Ulster as well. So there's 4 master courses available, and then people might go abroad as well to study in the UK. And again, these are 2-year full-time, and I recommend for both the undergrad and master's courses to look at the university prospectus and check with your guidance counsellor the requirements, because all the requirements can be slightly different. School subjects, as you can see, for the Trinity TU Dublin course, you need chemistry. We're looking at, I mentioned like we work out a lot of calculations as well, working out with the bloods what exactly someone needs from a nutrition perspective. So it's good to have that background to be able to interpret what recommendations we're giving. Biology, this is just a general interest in how the body works. We need to understand how our stomach works, how our gut works, how eating impacts our general well-being. And then home economics might be of interest to people because it does have a nutrition element there as well. And you can learn about, vitamins and minerals and some of the practical aspects as well to nutrition because, when you're advising, it's good to understand the practicalities of cooking, shopping, and, they can be quite difficult. And as like our social care colleagues, our social work colleagues even have mentioned, people need supports often when they're going home and mightn't be able to cook or shop for themselves. And then what I enjoy about my job, again, like it's really varied. So no day is the same, as everyone said here. You learn so much. You see a variety of different conditions. And you work like with a great bunch of colleagues, such a large department. And like everyone has to eat. We all have to have nutrition, either if you can't swallow through feeding tubes or through the veins. So it's really interesting and it's a growing science. You'll often see we're always learning about what's new with nutrition. You'll see on different, TikTok or different social medias, there's always something, new coming out about nutrition. But we're the ones that actually like filter through all of that information because often things can be quite misleading. And then we're the experts that are able to advise people on what nutrition they need. So they're the variety. And like people also said, there's great opportunities to like advance and to learn. And I've just finished a postgraduate course, so that's like a degree after doing an undergrad in healthcare statistics in Trinity. So again, that means I'll be able to do more research here within the hospital and help our patients. So there's a variety of opportunities here when working at St. James's. So thank you. And I'll finish with let food be thy medicine and medicine be thy food. So thanks everyone.
Hi everyone, my name is Jack and I'm an occupational therapist here in St. James's Hospital. I've been in James's now for nearly 3 years this summer and I'm currently in orthopedics, so supporting people after surgery, so like hip replacements and knee replacements. But I've worked in areas such as stroke rehabilitation, care for the elderly, I've worked in a nursing home and then the general wards, so respiratory and other kind of surgical and medical wards.
Hi everyone, thanks so much for coming. I can't believe it's been another year. Myself and Jack did this last year. My name is Clodagh and I'm a staff grade occupational therapist. I've been working here for about 1.5 years and I'm currently working in the inpatient oncology, so cancer services and on a surgical ward as well. I've previously worked on medicine of the elderly and the AMAU ward as well.
Great, so we're just here today, I suppose, to give you an introduction into like the world of occupational therapy. So what does an occupational therapist do? I suppose occupational therapy, or OTs as we often call ourselves, are healthcare professionals who support people to participate in the activities of everyday life. The primary goals of this are to support people's independence, health and well-being. And we achieve this by helping people to improve their ability to do occupations. So what are occupations? If you think about what are the things that makes us us, this can be anything which occupies our time. So from getting up in the morning, brushing your teeth, having a shower, going to the shopping, or doing our hobbies, all the way until we go back to bed. And we call this our activities of daily living. We divide this into 3 categories. Personal care, which is getting up, having a wash, getting dressed. Productivity, so for going for work for me, or going to school for you. And then leisure, so doing our hobbies. It's all the activities that are purposeful and meaningful to us. It also includes our roles and our routines. So like our daily routine and what we have to do and what our roles are. So for you guys as students and what you have to do and what I have to do at work, or think about your mum or your dad and what they have to do is their role as a parent. But occupations change over our lifetime. So what we have to do when we're little kids may differ than when we're older adults. So who do occupational therapists work with? I suppose we work with people across their lifespan, from little babies or little children to help them develop the skills they need all the way up into older adults, and to support them maintain their independence and let them allow themselves to stay at home. But I suppose for everyone that we're dealing with, we're looking, I suppose, to maintain their daily function for their day-to-day tasks and support them, I suppose, with their health and their well-being. So where do occupational therapists work? I suppose we here work in the hospital, in the mental health setting, or like myself and Claudia, in the physical setting, where we support people who are admitted to hospital, maybe for surgery or after an accident. We can also work in the community, where we support people to stay at home or do home assessments. We can work in various HSE organisations, private settings, or voluntary organisations, such as the Irish Heart Foundation. We can also work in nursing homes to support people's quality of life and function there, and also support them with kind of group work activities to keep up their quality of life. We can work in rehabilitation settings, so working with people, let's say, after a stroke. I've often done, as Alex said earlier, work with joint sessions with physio to help them recover with their arms and their function, and also looking if they need specialised seating, such as wheelchairs. We work with people with intellectual disabilities and in schools to support students. And we can also work in paediatrics, so that's working specifically with children. In some cases, we can work in equipment companies where we help them with assessments or recommendations for specialised equipment, including, I suppose, toileting equipment or wheelchairs.
Hello. So I'm just going to talk a little bit about how an occupational therapist think. So we like to take a bird's eye view or an holistic view when we're looking at our patients. So we would look at the person. So from your cognitive capacity, so your ability to attend to a task, process the information, store the information in your memory, and use this in executive functioning tasks. We look at the environment, so does the environment enable or disable you to engage in your everyday occupations? The hospital environment can be very different to your home environment. And then we look at the various different types of occupations that Jack has mentioned. So getting up, getting dressed, going to the bathroom, how can we adapt the occupation to meet the needs of the patient? So then in the centre of all these three circles is occupational performance. So when one of these is out of kilter due to an illness or injury, it can really affect how a person engages in their everyday tasks. So we would come along and assess and try and enable the person to engage in their tasks independently. So a day in the life, so as everyone has really said before, there's no 2 days that are the same, but we would come in the morning and look at our EPR for our referrals. We then might go and meet the patient, build a bit of rapport. I think that's really important. You don't just, go straight into assessing a patient, get to know them, conduct your initial assessment, get an idea of how someone was functioning before their illness or their injury, ask them about their home environment, what's important to them, what tasks they like to engage in. Are they working? Are they a full-time parent? Are they retired? We then will do our intervention. So we might provide equipment. We would always set goals with the patient, and they might go for a period of rehab. We work as a part of a multidisciplinary team with our allied health colleagues. We work in conjunction with families and relatives, providing education. Cognition, as I mentioned before, is a huge part of occupational therapy. We facilitate group work in various different settings and learning opportunities as well within our own teams and within the hospital. So a little bit about career progression, which is quite similar to what everyone else, the other allied health professions. So we start out as a staff grade, which is what both Jack and I are, for up to 3 years. You then can apply for a senior position, and then a clinical specialist as well, which we have numerous in James's, which is really, really great. And then you can apply to work in management or alongside Trinity as a practice tutor here in James's or one of the other colleges. Salaries then increase within increments as you progress through your career. So again, starting out at 44,000, going up to 97,000 at management level. We get 29 days annual leave, which is really great. And then I studied in Trinity. You were Cork?
It's Galway.
Galway. And so there's Trinity, Galway, Cork, and then at master's level you can do the masters in Limerick and Ulster as well. So what's the favourite thing about my job? I suppose the vast amount of patients you get to meet. You meet people from various different socioeconomic different backgrounds, and you really meet people sometimes at the worst days of their life. So going in and being able to talk to people about simple things like toileting, showering, promoting their independence, which is so important and we all take it for granted, can be really, really lovely to impact someone in that way and facilitate them to be able to engage in these activities again. Also, I think I was talking to one of my other OT colleagues about this. I've never come into work and said, oh my gosh, I've 2 hours till lunchtime. It's never like that. The day flies, which is it's a blessing. And working with such a highly knowledgeable OT department and allied health and departments within James's. And on the oncology team, there's a senior and a clinical specialist. So it's amazing to have that knowledge. So if anyone is thinking of working in allied health in any of the professions, I think starting out, it's working in an acute hospital is amazing opportunity for learning. So they would be my favorite things.
Yeah, I'm going to be repeating, I think, what the rest of our colleagues say is that they're all fantastic. You have a great team surrounding you you're working with. And at the end of the day, we are supporting people to recover and get them home at the end of the day. So it is very rewarding. You do come home kind of, that is something that I suppose the selfish of us that we get out of it is that we're supporting people and it is rewarding. Every day is different, as our colleagues say. There are different areas of OT which people like. So I love the hands-on experience. I like, I suppose, setting up the wheelchairs, making sure someone gets that seat that they need, that they can set out in the morning. However, there's also the interpersonal side. And if you don't enjoy, let's say, the physical side of OT, there's mental health areas, which is again counselling, supporting their quality of life. So there actually is a kind of an aspect for, if you like, I suppose, mental health and counselling and talking, or if you like the hands-on experience, there is, I suppose, both sides of the coin to that. So yeah.
Thank you for listening, everyone.
Thank you so much. I think everyone, if they could fill out the, I suppose, the QR codes, yes, there it is. Thank you very much.
Thank you.
And we'll have the panel discussion now just in a minute. Thank you.
Okay, so that's all the 5 presentations. Thank you to all of our speakers. So if you don't mind just taking literally 1 to 2 minutes, we're just going to set up for the panel discussion, have a quick look at the questions. I think there's a few questions in the box. For anyone who's online, if you've any questions, if you want to type them into there should be a chat or a comment box, and we'll keep an eye on them and we'll try and answer as many questions as we can. So we'll just give us 2 minutes. Thank you. Hello, 1, 2. Great, so hopefully you managed to access the survey. So as I said, any feedback at all would be great.
have a question if you want to.
Yeah, go on ahead there.
Sorry, Dermot O'Sullivan, guidance counsellor from the High School Dublin. Just, first of all, fantastic day. It was really great hearing that process about what is the difference between an OT and a physiotherapist. All that kind of stuff is great, a lot of sense. So well done on the day. Getting into the course that you talked about in college is going to be a big barrier for a lot of students here. You did talk about alternative ways of getting in. Would you have any comment about how difficult it is, or maybe in your experience, to get maybe qualifications somewhere like Ulster or UK, come back to the Irish health system?
I actually applied to the... Oh, perfect. I did go to Trinity College, but I as a backup, and also my older sister did as well, so I just kind of copied her really. But I applied to the UCAS system. So from memory, which is a couple of years ago now, so it's not going to be a great memory, but I think you have to do a kind of a personal essay to get into the colleges. So you apply to about 5 different colleges. So I think I applied to Queen's University, Ulster University, Manchester, and then maybe 2 in Edinburgh. So did like a big long personal essay. I got, I think, my teachers and my aunties who work in healthcare to help me with that. And then once that's sent off, they kind of review that. It is kind of conditional on if you get the grades first. So you have to like check what grades you require for these courses. But from that then, just for allied health, I think specifically, you have to do an interview if you get acceptance in college. So I got accepted into Queen's and Manchester. So I had to go up to Queen's and then over to Manchester to do that interview. And they kind of get you to do the interview first. And then I think you kind of do, it's nearly like a quick assessment of how you would manage a situation. So they would have actors there that you would have to interact with, and they kind of give you a scenario and you'd have to manage this patient or the actor basically within this scenario. And then they grade you on that. So there's kind of like 2 components, I suppose, to getting into the courses in the UK. So first of all, the personal essay, then the interview, and then is conditional on whether you get the grades or not for that. That's just from memory though, so it might have changed in the last couple of years.
Or when you do get your qualification, you actually practice.
Oh, sorry.
I can speak on that if you want.
I am the Deputy Speech Therapy Manager in the hospital, and I've just returned from working in the UK for the last 10 years, so can probably answer your question. So there's registration bodies associated with each of the professions. Here you need to be registered with CORU. In the UK, you're registered with RCSLT. And to register yourself with CORU, there will be courses that are accredited. So obviously, if you study in Ireland, you get accredited straight away. Whereas if you're coming back from the UK with a UK course, you have to get accredited through CORU. So the process is longer in terms of getting your registration through, and they'll look at the number of hours of clinical placements and stuff that you have so that you can, so that it's equal across the board. But it is very possible. It's just a case of making sure that you keep up those hours throughout your studies.
Would it take an extra year?
No, just a couple of months longer. And for some of the professions, I know for speech therapy specifically, because there's a slightly different element around the swallowing, they'd have to do maybe some more hours in swallowing before they could come back. So might need to practice a little bit in the UK before they came back to meet that registration requirement here, because, and it would depend as well which institution you study at in the UK.
And social work is quite on the power as well. It's just a matter of getting CORU registered. So the qualification would be seen as the same.
Just on physio as well, so as I mentioned before, we do musculoskeletal, respiratory and neurology are the 3 big areas. Some European courses don't do respiratory, but in order to work in Ireland as a physiotherapist, you need to be respiratory trained. So for example, the Netherlands is an example of somewhere that doesn't do that. So if you qualify in the Netherlands in order to get CORU registered, you would have to come back to Ireland and do additional placement hours that have been signed off by CORU as called a period of adaptation. What I would recommend for people looking at studying abroad is speaking to physiotherapists who have been through that route prior and seeing what additional things that they needed to do after their degree. In regards to physio from coming back from the UK, it's a little bit longer to get CORU registered. Their college courses end at the same time, and it's normally kind of 3 or 4 months longer that it takes to get registered. What lots of people do is they work in the NHS for a year, and don't worry about getting their CORI done quite quickly, and then once they have their CORI done, they'll move back, but they'll work in the NHS in the meantime.
Sorry, the last point on that, it kind of mirrors what the others have said, but for most of the colleges internationally around the world, and specifically for occupational therapy, there's a World Federation, say, of Occupational Therapy Colleges, so WFOT it's called, and so they accredit a series of universities throughout the world with the OT qualifications. So say, for example, you're coming back from abroad as an OT and you're looking for this CORI registration. Once CORU see that you attended a WFOT university, it kind of fast tracks you into that kind of CORI registration process. So it expedites it. So I suppose from our perspective, it's really important that the university, if it's abroad or be it that it has this World Federation accreditation. So there's a couple of kind of tricks and tricks around it. But yeah, it's just to kind of have that insight, I guess, in the inner inside knowledge. Yeah.
Great, thank you. We might move on to a question from the box. So this one is directed towards the social workers. If you see or hear upsetting things, do you find it hard to not take that home with you?
Yeah, I think that's a really good question, and I suppose that's something that comes up a lot. We obviously work with people who are going through really, really difficult times in their lives, and the hard thing is to not bring it home, but you have to, I suppose, practice a lot of self-care in our job and make sure you mind yourself too. And we get a lot of support in our department from our colleagues as well, through supervision, and kind of checking in with each other. So sometimes there can be really difficult things, but I think that, I suppose, through your training and your experience over time, you kind of learn how to manage them and how to support the person, and I suppose help them to overcome their challenges. Do you want to add anything to that?
Yeah, I guess I'll just add that supervision is central to our role. We're kind of privileged that it's something a requirement almost. So it's informal and also formal supervision on a regular basis. So that is a space where you can debrief and reflect on how things are impacting you and help you to manage the emotional levels of what comes up. And also, I think personally, what I find in a lot of the work where there is a lot of grief and loss and sadness, that also there's often resilience. There's huge resilience of the people that we work with, and it's just identifying that side as well, which makes things worthwhile. Yeah.
Great, thank you. And is there any other questions from the audience, and we can get Clodagh to go up with the microphone?
Thank you so much. I was looking forward to asking this even at the beginning, but my question is, I see the talks were about transitional students.
Mm-hmm.
I'm a healthcare assistant. I've been here since 2019, and already I did a bachelor's in adult and community education, and I did a diploma in secondary education, and I'm registered with the Teaching Council of Ireland already.
Mm-hmm. And
then I did FETAC level 5, and then I did postgraduate in social care from Carlo.
Mm-hmm.
And I'm in the process of registering with CORU.
Okay.
But I am interested in becoming an occupational therapist. So at this stage, I just want to know what is the ideal course that I would do, because I've done all these courses and I've not been using them. So it seems like I didn't focus well what I wanted to become and what I was studying. So with all the bachelors, the diplomas, the masters in development studies, they're all, I can't make use of them. So I just need to be helped. How can I become an occupational therapist when I'm already practicing as a healthcare assistant? Thank you.
Yeah, I'll try and answer this as best as I can.
So because you have a bachelor's already, you would be looking at doing like a master's degree, because one of the requirements to get into the master's degrees, so up in Ulster or in University of Limerick, is to have a bachelor's degree. So part of that process would be applying to Limerick, submitting your bachelor's degree. It would also be, as the guy said, submitting an essay of interest. So you'd have to look, I suppose, at the CAO just to see, when it's coming up on the positions there, and apply that way. And it is a 2-year degree. So I have one of my friends who's just finishing the degree this year. He did a bachelor's degree in something that was unrelated to occupational therapy, and then decided that he wanted a career change and decided to sign up for University of Limerick. And that's what he's been doing for the 2 years. And once you have that, then that's will be your way to get into occupational therapy, and we'd be lucky to have you.
Great, thank you. Thanks, Jack. And just one more here from for speech and language therapy. Are there options to go into research?
Yes, that's certainly a space that you can move into as a speech and language therapist, and you can start off even as a staff grade by contributing to data collection for research projects, but then it's certainly something, I mean, you can go into straight out of university by, I have a friend who applied to do their PhD or like a thesis and contribute to a research team ongoing at university instead of going clinically. I don't know if that's available in Ireland as well to go straight in. Yep, it is. There you go. And then, yeah, continuing to have those university links, and you can definitely go into research.
Just to say as well, if you're interested in research, there's always opportunities if you're a college student to work like as a work experience with some of the researchers that do research in cancer, or there's physio ones as well. So there's always options, but Coru websites are really good, and they give loads of details on stuff like that. So, and even within James's, like audits and research and stuff like that and projects, it's definitely an interesting area, but there's so much options here as well with it. So.
Brilliant, okay. Any other questions? No. So we might, I'm conscious we said we'd kind of finish up in or around the 3 o'clock time. So I'd just like to highlight, so we're 5 professions within the health and social care professions, the HSCP. There are 26 professions, including pharmacy, optometry, audiology, medical scientists. There's a huge array. So it's definitely worth having a look on that website. So it's health and social care professions. And thank you so much for attending today. Thank you so much for your attention. You've been a great bunch. And thank you to the speakers today as well. And hopefully you found it really useful and informative. And who knows, in maybe the next, in the next maybe 5, 6, 7, 8, 9, 10 years, who knows? It'd be great to see you back again, and we'd welcome you with open arms. Thank you so much.